All right, so part one, annual wellness visits. Today we're going to go over an overview of the CMS preventive visits. We're going to take a look at the required elements in an annual wellness visit. We're going to review the coding and billing requirements for that visit. Take a look at the optimal workflow, and then also answer any questions you may have. So under the ACA, private health plans now have to provide coverage for a range of preventive services without imposing any cost sharing on patients receiving those services. This is a really sort of new development. Prompted by the ACA, Medicare began paying for an annual wellness visit, which was new for all Medicare beneficiaries. So when we think about what that means, we're sort of trying to direct care to the primary care provider. CMS says, we're trying to save money. Let's get everyone to their primary care provider to provide these preventive services. And we're going to start paying for those services because we value them. We think that they save money down the line. So then in 2013, CMS began paying for a transition of care visit. And we're going to review TCM in our next webinar, the second part of this series. So from 2011 to 2013, CMS said, let's really start trying to reduce readmissions. Let's bring the patients back to their medical home. Let's have them visit the primary care provider again following a inpatient admission so that we can, again, direct care to the primary care provider. And then in 2014, CMS started paying for chronic care management services, otherwise known as CCM. That will be part 3 of our webinar series. So the goal there was to really keep patients out of the hospital. So instead of going into the hospital, we want to keep them out. So we went directing care to the primary care provider, reducing readmissions, and then now we're going to try and keep them out of the hospital altogether. So a little brief overview of each service before we dive into annual wellness visits. The annual wellness visit is known as an AWV. It's a comprehensive care planning visit that includes the completion of various screenings and a health risk assessment. It is not a head-to-toe physical. This is very important, and we'll get into that a little bit later. The patient and the healthcare provider create a prevention plan based on a health risk needs assessment. So the AWV is really a care planning session. It's a comprehensive review. It's a chit chat, right? It's my time to sit with my PCP and download all of my health information. Transitional care management, the TCM visit, is a service provided following a discharge. So following an inpatient stay that includes both non-face-to-face and face-to-face interactions. The visit is for patients who have medical or psychosocial problems that require moderate or high complexity medical decision making. I don't know about you all, but I'm pretty confident that most Medicare patients fall into this category. Maybe some of the younger ones, the ones that are just joining Medicare, may not have complex medical or psychosocial problems, but certainly as we age, we see more and more of those problems existing for our patients. Under the TCM visit, the healthcare provider really takes responsibility and ownership and accepts the care of the patient following discharge. So again, we're redirecting that care. Patient gets discharged. They're sent home with lots of information. How do they manage it all? And Medicare wants us to reassume responsibility of that patient after a discharge. And the last preventive service we're going to go over in this series is chronic care management. So now, how do we keep them from getting into that hospital? How do we avoid that admission? CCM is reimbursement for non-face-to-face services provided to patients who have multiple, which is defined as 2 or more, significant chronic conditions. And these services include communication with the patient, also communication with other treating health professionals for care coordination. It includes medication management and being accessible 24 hours to the patients and any other care providers, and also the creation and revision of a care plan. So CCM is really unique in that it reimburses for specifically non-face-to-face services. We'll dig into CCM more in part 3 of this series. All right, so let's take a look at the annual wellness visit. There are many required elements in an annual wellness visit in order to be done correctly. So we'll split those into 3 sections. We have our beneficiary information that we have to collect, the assessment that we complete, and counseling on behalf of the healthcare provider. So under the beneficiary information, the provider or clinician is going to administer a health risk assessment, otherwise known as an HRA. The HRA is very comprehensive. It collects self-reported information, and it's tailored to communicate what patient needs exist. So do they have limited language skills or literacy needs? It collects demographic data. It's a self-assessment on behalf of the patient's part of their health status. Are there any psychosocial risks present? Behavioral risks? Are they able to complete activities of daily living? This beneficiary information section is also going to require establishing a list of current providers. This is very important in order to create the patient's circle of care. Also establishing complete patient medical and family history, understanding the patient's own medical history as well as any conditions that are present in their family, and this is very important when we get to the billing and coding piece. A review of potential risk for depression. The PHQ-2 and PHQ-9, if necessary, are part of this visit and included in the code. And then finally, a review of functional ability and level of safety. So you're going to want to assess fall risk and whether or not their living situation is set up appropriately to keep them safe. So those are all of the elements required in the beneficiary information section. Then we have the assessment, which is a little more typical when you think about an annual exam. You're going to assess height, weight, BMI, and blood pressure, so all the vitals, and then also detect any cognitive impairment. And then the last section is counseling. So this is a huge part, in addition to the beneficiary information. This is probably the largest section of the annual wellness visit. The provider is going to establish a preventative screening schedule that the patient and their caregivers are aware of. The counseling is also going to include a comprehensive list of risk factors and conditions that may impact the patient's care. Also, furnish personalized health advice and appropriate referrals to education or other counseling services. So the annual wellness visit is the opportunity for the primary care provider to connect that patient with any other resources that he or she deems necessary. And then also the last piece is, at the discretion of the patient, completing an advanced care planning service. So that's going to be creating their advanced care plan for end of life so that everything is on file. And this piece actually warrants an additional code, and we'll get to that in the billing section. So who can provide an annual wellness visit? Physicians can, obviously, a physician assistant, a nurse practitioner, or a certified clinical nurse specialist. In addition, a health educator, registered dietitian, a nutrition professional, or other licensed practitioner, and anyone who is directly supervised by a physician. We find that a team-based approach to these annual wellness visits is the most efficient and cost-effective approach, and we'll get to that when we dig into the annual wellness visit workflow. But it should be mentioned that a physician should always be signing off on the wellness visit, a physician or a advanced practicing professional, so a PA or a nurse practitioner. And we've seen lots of very interesting leveraged models that work quite well in practices. So we're going to take a pause for a polling question. So if you all would humor me, I'm going to launch a poll. You should be able to see it now. Is a physical exam part of the annual wellness visit? And if you want to record your answer, I'll give everyone about 20 seconds. All right, still waiting for a few more people to cast their vote. All right. So let's share these results with you. So most of you got it right. A physical exam is not part of the annual wellness visit. That is correct. It is not a head-to-toe physical exam. The annual wellness visit, you want to think of it more as a care plan, planning visit, a health risk assessment visit. It's a chit-chat. It's a discussion. It's a discussion with your provider and an opportunity for patients to gain and share resources and get connected with other providers, as well as establish a preventative screening schedule. Great. So let's continue. So what are the codes that, that we can use for these annual wellness visits? There are a few different types of annual wellness visits. Medicare likes to keep it interesting. So we have the initial preventative physical exam, otherwise known as the IPPE. And the code for that is a G0402. So again, this is a face-to-face visit. This service can only be furnished during the first 12 months of Medicare enrollment. All right? So something to remember here, the first 12 months of Medicare enrollment, our average Medicare enrollment age, right? Let's say we all enroll at age 65. 65-year-olds are pretty healthy. I think about my parents. They're almost 65. They're doing well. How do we get them in for this initial preventive physical exam? We have to get them in during the first 12 months in order to build this G code. Some other codes that may be associated with this initial wellness visit include an ECG. So you can see G0403 through G0405 are ECG codes that include various additional services, interpretation and reporting that can be billed in addition to the annual wellness visit code. So our requirements, again, it's 1 IPPE per patient per lifetime, and it has to be within that first 12 months of the effective date of the patient's first Medicare Part B coverage period. So once they enroll, you have 12 months to complete the IPPE. And then all of the components we discussed in the previous slide have to be completed prior to submitting the claim. We have to collect all the patient information, complete the assessments, and then perform the counseling services. The reimbursement rates over there in the right-hand column are for reference. This is a national average. So remember that your Medicare reimbursement will be adjusted based on your geography, based on your MAC locality. The next two annual wellness visit codes. So we just talked about the IPPE. Now we're going to talk about the AWV. So love the acronym soup here in Medicare world. So the codes for these are G0438 and G0439. How are these different? So the G0438 is your initial annual wellness visit, not to be confused with the IPPE, or initial preventative physical examination. So the initial annual wellness visit is the first formal AWV, which is going to include your personalized preventive plan of service. This is going to occur in your, ideally, in your second year of Medicare enrollment, right? So this code, the 438 code, cannot be billed within the first 12 months, because if it's within the first 12 months, you have to bill the IPPE code. And then following the second year of enrollment, starting in year 3, we're going to start billing for the subsequent annual wellness visit, G0439. So this is going to be every annual wellness visit moving forward. So after year 3, we're going with the subsequent annual wellness visit for the rest of that patient's time in the Medicare program. So again, the billing requirements, this AWV cannot occur within 12 months after the effective date of the patient's first Medicare Part B coverage period. And you want to notice too that the reimbursements here are different. So we really want to make sure we take advantage of that G0438 code, the initial annual wellness visit. It garners a much higher reimbursement. So we want to make sure we accomplish that in year 2, and then in year 3 we start doing the G0439. The patient cannot have had the initial preventative physical exam or the initial AWV within the last 12 months in order to bill one of these codes, right? Medicare only allows 1 per year. You can only bill the initial wellness visit once per patient per lifetime, and then the subsequent once per year thereafter. And finally, this is really important, You should always, of course, report a diagnosis code when submitting a claim, but it's especially important to submit a comprehensive list of diagnosis codes for your annual wellness visit. You want to choose any diagnosis code that's consistent with the patient assessment. So often we see those Z codes being used, the encounter for normal, preventative visit. And we want to stay away from that because we know most Medicare patients have pertinent diagnosis codes. And it's within the scope of the visit to really code for the issues that the patient is presenting with. We want to take advantage of this. This gives us an opportunity to capitalize on HCC scores. So we want to accurately code all of the diagnoses that the patient presents with. It is within the scope of the visit to code all of the pertinent diagnoses. Time for one more poll. Let's see how well everyone has been paying attention, or more appropriately, how well I've been describing everything. So we're going to launch this poll. Can the IPPE be done 12 months after the patient's effective date of Medicare coverage, period? So if I'm a Medicare patient and I enroll in March of 2017, can my IPPE be done in April of 2018? Give everybody a few more seconds. All right, great job. Everyone did a good job. No, the IPPE can only be done within the first 12 months of Medicare coverage. So great job there. I'm glad that that point has been well understood. Let's talk about advanced care planning codes. These codes can be built in addition to the annual wellness visit code, and they are advanced care planning includes the explanation and discussion of advanced directives, right, by a physician or other qualified healthcare professional. So these are time-based codes. So you'll see that the 99497 is the first 30 minutes, and then the 99498 is each additional 30 minutes. And you can list these codes in addition to the primary reason for the visit. So in this case, if you're building these with an annual wellness visit, you'd have your G code first, and then your advanced care planning codes would follow. Also remember, you must report a diagnosis code when submitting a claim for an advanced care planning visit. So you should choose any diagnosis code that's consistent with the patient assessment. Again, this is an opportunity to get those diagnosis codes in for accurate HCC scoring. So please, please try and select a diagnosis code that is pertinent and avoid those Z codes if at all possible. It's also important to note here that ACP codes can be billed with a traditional E&M visit. So let's say you have a patient that comes in for a sick visit, a 9921413, and they say, hey doc, I want to do my advanced care plan now. You can go ahead and do that in addition to your E&M visit as well. I will say, workflow wise, it tends to be efficient if the advanced care plan is completed during the annual wellness visit. It just makes sense, right? The patient is coming in, they're having their discussion with their doctor about their health needs, they're reviewing a full risk assessment, and then it segues very nicely into creating an advanced care plan. So let's talk about the workflow. We have here swim lanes, and we've got each team member that's going to be involved in the annual wellness visit in the first column, and then the tasks that they will follow in order to help the patient through the annual wellness visit in the boxes in the flow chart. So this is really what we view as an ideal workflow. It can work a little bit differently in each office, but we feel that if each of these team members is integral to the process, and if each of these team members can accomplish their tasks, then the visit is accomplished efficiently, and there is a big return on investment. So the front desk staff would be responsible for running a report of patients that received an annual wellness visit in the last year during the current month, right? So, okay, it's January 1st. I'm ready to get my first batch of patients for annual wellness visits scheduled. I'm going to look back 12 months and see who received their annual wellness visit. And then I'm going to pick up the phone and I'm going to call the patients to schedule their AWV. What we've noticed is patients aren't going to proactively schedule these visits. It seems sort of strange because they're provided at no cost to the patient, but a lot of patients don't know about them, don't understand, and we'll review on how to market the annual wellness visit in the next slide. But it is really important, this step is important to proactively schedule your patients. So after we call and we schedule their annual wellness visit, we're going to verify that the patient enrollment date and the last time the patient had their annual wellness visit. There are systems in place. Novitas actually allows you to check this online. You can verify the last time Medicare has paid for an IPPE or annual wellness visit. And then the front desk staff is going to ask the patient to complete the health risk assessment, fill in their history, and complete a PHQ-2. We've found that if the patients can do this on the portal or even in paper form before the visit, it really helps the visit run smoothly. It helps the provider be able to spend the appropriate time with the patient, not just doing paperwork. So the portal is a great option if you have the availability to do that, or if you want to hand the patient the forms when they come in, ask them to come 15 minutes early. Whatever workflow is best in your office, the point here is get them to complete the information ahead of the scheduled visit. So now if I'm the patient, I'm going to complete my questionnaire prior to the visit. I'm also going to make sure I bring a list of my current medications or bring all my medications in a bag. I used to work in a practice and we would say to the patients, just put all your meds that you take in a gallon Ziploc bag and bring them with you. That makes it really easy for us to keep the medical record up to date. It allows us once a year to reconcile the medication list and make sure that we have everything accurately documented. And then also, if I'm the patient, I'm going to bring a list of all my providers so that my PCP knows who I'm seeing and a list of my vaccines so they know I'm up to date. So once the patient is scheduled, the patient arrives for their visit, we're going to have the medical assistant or the nurse, whoever that may be in your practice, go ahead and assess the vitals, get their height, weight, BMI, and blood pressure. And then they're going to go through the patient functional ability and level of safety assessment. And then they're going to confirm all the information that the patient filled out ahead of time and enter that information into the EMR. So ideally, we've queued up for the provider everything that they need to make this visit, to meet all the billing requirements for this visit before the provider even sees the patient. So then the provider is going to meet with the patient and review everything that they've submitted ahead of time. They're looking at this in their EMR and they're going to check off that the medical and family history is complete. They're going to assess the cognitive impairment, do those assessments right then and there. They're going to establish a schedule for preventive services, and then review the health risk assessment as it was entered in by the medical assistant. They're going to prepare a list of risk factors and conditions, and then compile the health risk assessment, the preventive services schedule, and the risk factors into a comprehensive care plan. So it's at this step where we can see how a comprehensive electronic medical record template is very, very important. If we have all of these steps templated out for our providers, and for this type of visit, a template is ideal, right? Because we just need to meet all of these requirements. Then we can make sure that we have captured all of the necessary information in order to bill. After they've created the care plan, the provider is going to give any referrals for education services or additional specialists as they see fit. They may complete the advanced care planning if that's something that the patient is interested in doing. And then finally, they're going to share with the patient a copy of the full care plan and also with the patient's caregivers if necessary. So how do we get patients into the office for this visit? This is sort of a landmark study on Medicare preventive services and specifically the annual wellness visit. And unfortunately, the data is a little old. It was conducted in 2014, and they're still writing articles on this data. So I'm anxious for someone else to come out with some refreshed data. But what this study said was that only 15.6% of patients received their annual wellness visit. So when you think about that, that's incredible opportunity to get these patients into your office. And when they thought about why, why aren't patients coming into the office to get their annual wellness visits? It's primarily driven by practice factors. Some physicians and health systems are incorporating strategies such as templates and workflows, dedicated non-physician health professionals to complete and document visits. And another reason is annual wellness visits are often co-billed with problem-based visits, which actually transition some of the cost onto the patient. So we want to remember that these G codes, the preventive service codes, they are no cost to the Medicare patient. But if they are billed in conjunction with an E&M or a regular office visit, there will be a copay. So we need to make sure that we market these annual wellness visits effectively, right? We want to make sure that it is explained to the patient that this is a care planning visit. This isn't your annual physical, so don't expect to need to take your clothes off, right? This is about discovering any health risks that you may have, reviewing your patient medical history, your family history, and that if we do address an issue, to make sure that's communicated with the patient clearly. Hey, we're going to talk about your diabetes now. We might make some adjustments on your medications. And if we dig in any further, this is going to be billed as an additional visit. Or maybe your ideal workflow is, okay, we need some diabetes management. Let's schedule you for a visit in the upcoming week for that. It's very important to get patients into the office proactively using things like postcards. How many of you get a postcard from your dentist or your vet? Oh my gosh, for my cats, I get postcards all the time. Your cat is due for X, Y, and Z. That's amazing practice, and we should be doing that in our primary care setting. Our front desk staff should be equipped with a script, and they should be educated. They should understand what the annual wellness is, what the purpose is, and be able to encourage patients to schedule their annual wellness visits. So, these numbers are staggering. If we have a 500 patient panel and only 20% of them get their annual wellness visit, we have over $48,000 a year that's being left on the table. This is a lot of money in practices that run very lean. So we definitely need to capture that revenue, not to mention the opportunity that we have with annual wellness visits to capture all of the diagnosis coding for an accurate HCC and risk profile of our patients. So with that, I would love if there are any questions. We have about 3 minutes for questions. I'll give everyone about 30 seconds to see if they have anything and go ahead and submit it into the chat box. Okay, we have a question here. Can the provider get an annual wellness visit from another provider? Can the patient get an annual wellness visit from another provider? Yes, absolutely. Any Medicare credentialed provider can bill for an annual wellness visit. In fact, there are companies out there that will run health fairs and offer a free screening visit. And essentially what they're doing is they are giving their patient their annual wellness visit and then billing Medicare. We really want our patients to get their annual wellness visit with their primary care provider. That is the whole point, right? The point is that the primary care provider has continuity of care, understands this patient best, can create the most comprehensive and operational and useful care plan. So we really want to make sure that we proactively schedule these patients. What is the correct cost? What is the cost of the annual wellness visit to the patient? So again, if it's just the G code that's billed, there is no cost to the patient. If you do bill the annual wellness visit and then you add a 25 modifier and bill another service, then there will be additional cost. The ECGs have cost sharing even if done during the IPPE, correct? Yes, that is correct. The ECGs do have cost sharing associated with them. Again, it's only the preventive services, the G codes, that are at no cost to the patient. We have another question. Does the exact time for the ACP have to be documented in the note? Yes, these are time-based codes, so we recommend that the time is documented in the note. If there were 30 minutes spent with the patient completing advanced care planning, that would be appropriate. Great questions. Great questions. I'll hang on the line for about another minute and see if there are any other questions that come through. Otherwise, thank you very much for joining. Again, this will be posted on our website for anyone to review. And we look forward to part 2 on transition of care visits.